I am SEM class of 2015. I am also a tri-chair for the HCAE, which is the Heads Council on Alumni Engagement. One of our flagship programs is this type of panel discussion, which we call our Alumna in Action Speaker Series, where we host these types of discussions throughout the year, where we highlight topics that we know are interesting or pertinent to our SEM community, and we feature and highlight our incredible SEM alum to provide their expertise and share their wisdom with us. So tonight, I am very fortunate to be joined by 4 panelists and 2 moderators to discuss women's health and healthcare access. So I know it is an exciting topic. I will not bore anyone else with my words, and I will pass it over to my fellow HCAE members and our moderators for tonight, Eliza and Jamila. So I'll pass it over to you guys.
Thanks, Jane. All right, well, we're so excited to be here. Jamila and I are going to do some introductions of our panelists tonight. So first, I'm Eliza Kay. I'm an alum of SEM, class of 2012, and I currently live in Chicago.
And my name is Jamila Lee. I am a graduate of SEM as well. I graduated in the class of 2006, and I currently reside in Buffalo.
So, Jamila, do you want to kick us off with our introductions?
Sure. So first, I am proud to introduce Dr. Asha Subramanian. She's from the class of 1990. She is a board-certified family physician and lifestyle medicine physician with specific expertise in evidence-based lifestyle change. She currently works with the underserved community and the Community Health Center in Washington, D.C. Dr. Subramanian, her professional interests include lifestyle medicine and the use of nutrition, exercise, sleep, meditation, meditation, mindfulness, and other strategies to optimize health behavior of change, health advocacy for underserved communities, health literacy, and teaching others about whole food, plant-based nutrition. She plans to speak more about this later on today.
So I am happy to introduce Nat Voos. He is class of 2014, currently a 4th year medical student at University of Buffalo, but actually he just found out that he will be starting residency at UPMC Pittsburgh for pediatrics, which is super awesome and exciting, huge accomplishment. So, almost Dr. Voos is particularly passionate about LGBTQ plus healthcare and trans rights. And he was awarded a fellowship in social justice, equity, administration, and leadership while in medical school. So we'll hear from him on many of those topics too tonight. Next,
I'm proud to introduce also Justice Amy Martoche from the class of 1988. Judge Martoche is a New York State Supreme Court Justice, elected in November of 2020. She formerly served as a Buffalo City Court judge, where she founded and presided over the Human Trafficking Intervention Hub Court from its inception in 2013 until she started her new role in Supreme Court. While she served in Buffalo City Court, she also presided over the domestic violence part, where she adjudicated more than 8,000 cases. In 2011, Mayor Byron Brown appointed Judge Martoche to the bench. Justice Martoche is also a proud graduate of the Buffalo Seminary, which I stated earlier, and she also serves as a chair of the Board of Trustees.
And then lastly, I am happy to introduce Dr. Emma Berntheizel, class of 2011. She specializes in perinatal treatment for women to address musculoskeletal pain during pregnancy. She's a chiropractor in Boston, Massachusetts. She was trained in a variety of topics within women's health and perinatal and postnatal health, and she's currently at a sports medicine clinic as well.
We will also just like to remind you all that everyone's bios, we have such wonderful panelists, are available online, and we encourage you all to read their bios more thoroughly. We have terrific panelists in front of us that you can learn more about.
Thanks, Jamila. All right, so we're going to jump right in. We have many topics on the docket that we'll hear from everyone on the panel and just share their different perspectives, and we'll hear a lot of great insight into these topics tonight. So first, to kick us off, I want to start talking about access to healthcare and how that's changed over time. So specifically, is access to certain healthcare types more difficult than others? Maybe that means physical versus mental health versus any other type of health, emotional well-being. And how does medical access and accessibility differ by populations and communities? And I know each panelist has a really unique perspective on this. So whoever wants to jump right in, we can start hitting on all the points. About Dr. Subramanian, we'll just call on you first. And if you want to just start sharing a little bit about your insight into that topic, and we can bounce around to the other panelists.
Sure. Access to healthcare has been, over the years, has been a really hot button issue, has been a difficult issue. Obviously, the Affordable Care Act that was passed under the Obama administration did help somewhat with access to care, but it still remains a huge barrier to, many populations. I specifically work with underserved populations, meaning that many of them have no insurance, or they have Medicaid essentially because they are the working poor essentially. And, we find that we as primary care providers, we're able to see them at the community health center, but then we are unable to find folks specialty care. Like, it's really hard to get people into any kind of specialty care. It's months and months, sometimes years. Mental health care is another, huge barrier. And I would say not only in the underserved milieu, but also in just in general, in the general community. So, I worked for many years in a large group private practice as well here in outside of Washington, D.C. And mental health was a real barrier as well. I can tell you, though, at the community health center, we're really blessed because we have a whole team of emotional wellness specialists right on site who are able to connect to our patients. So, those are some of my thoughts.
I can just bounce a little bit off that. So from like an adolescent perspective, I'm going into pediatrics, so that's kind of what my brain focuses on. From like a pediatric perspective, there's a couple kind of areas that I think we see a lot of disparate care in, and I think one of the big ones is mental health. With the COVID pandemic, with everything that kind of kids see today, social media, mass violence, climate change, everything, I think it kind of has conglomerated into a huge adolescent mental health crisis. And, in Buffalo, and I think, throughout the rest of the United States, we don't have a lot of access to quality emergency psychiatric care, long-term psychiatric care, alternatives to hospitalization, just shortages in psychiatrists, things like that. So I think that's kind of one area that we see in adolescent medicine as well right now. That's kind of going to be I think a more pressing issue as we go forward, and kind of these problems just kind of keep rolling.
And I would just dovetail, it might not seem like it fits, but as a judge who handles criminal cases, we see people who have mental health problems who then self-medicate, who then get into legal trouble. And so it's cyclical because there's just not great mental health treatment for people who can pay, let alone for people who can't pay. And so that's a real fundamental, it's a fundamental problem that I think as a society, we've really got to figure out how to address. because otherwise it's just a circular chain or something, just keeps going.
I think for a lot of the things we talk about, you have like lack of access to care leads to disparate health outcomes, leads to like socio, criminal implications, leads to lack of access to care, so I think there is that huge circle and like at many of the things that we're going to talk about today. So just keeping that framework, I think, exists for a lot of things in healthcare today and outside healthcare.
I also think even just the barrier to entry a lot of the time for getting a primary care doctor, even in a large city with, there's a lot of different socioeconomic statuses that I see on a daily basis who, there's a wide spectrum and a lot of people struggle with even just getting a primary care doctor because of waiting lists. Same thing with therapists. I think the number of people just trying to get a referral is wild. So I think just getting in the door a lot of the time is the biggest issue for people, and then they can get access, but it's so siloed that even just the bare minimum is really a challenge. So I think that's worth noting too.
Not
I
to,
also-
sorry.
sorry.
No.
Oh, I was going to say, from Dr. Berntheisel's comments that, in my daughter goes to our local public school. She's in 3rd grade, and they have one counselor for 650 kids. I mean, that is just stunning. Think about that. 650 kids, one counselor. And, this is not an uncommon problem. It's just, it's essentially an epidemic, of a crisis. It's a crisis that we all need to be aware of, and we all need to, help address. And part of it is addressing it from policy change. Myself or Dr. Voos, I will call you, as we progress in our medical careers, and, Judge Martoche and Dr. Berntheizel and all of us, we are in the field and we are seeing these folks face to face every day, but you all in our audience can make a difference by writing to your Congress people, your representatives, your school board, all of those people, mayors, wherever you live, and talk about how our kids do not have enough counselors, who don't have enough mental health resources. I mean, I see so many kids from all walks of life who are in crisis, and the COVID pandemic has just rocketed this, unfortunately, into clarity. But it was there all along. But it's just, gotten so much worse. So, that would be a call to action for this audience that I would like to see happen.
You actually segued perfectly, because I was going to ask, before going on to any more topics, if you all could share insight as to what some solutions are. So you touched on policy changes, but what else can we be doing? What else should we be talking about that could mitigate some of these issues? Because it is an epidemic, I think. I agree.
I think I'm taking currently a course on like pediatric advocacy, and so I'm stealing this from somebody else. This isn't my, this is advice I recently got, in that like a lot of advocacy comes just from education. So talking at something like this, or going to, if you have a book club, just like talking about these issues and getting engaged and educating other people on things that they might not know, and learning from what they know that you might not know, is actually a huge part of advocacy. So things like this are actually kind of important in the discussion, and advocacy has to be actionable. So taking that next step of policy change is necessary, but education is also, I think, the grassroots, the baseline of it all.
I couldn't agree more with you about education and essentially proselytizing among your friends and family. And I think that we all like to, we think about being fiscal conservatives and not wanting to spend money. But, the truth is, if we don't spend the money on the mental health care, on the education piece, when people are children, we have a lot more remediation to do when people become adults, because they're just bigger people with bigger problems. And I think we just need to figure out how to to start off and look at it a little bit differently and a little bit more holistically. Because it's really sad. You know, I sat in Buffalo City Court for many years, and you see people who just didn't have the same opportunities, didn't have the same access to a whole lot of different things. And so I think there needs to be a shift.
I think too, just to go off of Judge Martoche's point, really emphasizing both in a policy perspective and also with sharing your own experience with your friends and family. I think emphasizing the proactive and not reactionary kind of healthcare is a really, really valuable way to kind of frame it for people, that you will end up spending more money, having worse symptoms, having a scarier diagnosis down the line. And maybe, you know, we'll even end up in an emergency room with a much bigger bill versus having something, you know, a lot of this is policy change, but a lot of it is really talking about it early and sharing what's going on. And from my perspective, which is very much a lens of pre and postnatal care, a lot of the women and the people that I treat have no idea that what they're going through is not only, you know, it's not necessarily normal if it's common. So advocating for sharing of your symptoms and talking about what's going on, even if it's uncomfortable, can be the small scale solution in a lot of ways, and then scaling that upwards and really voting for and advocating for the proactive and preventative healthcare models, I think is going to be huge.
As it extends to mental health too.
Right.
I mean, because there are just a dearth of providers of mental health care. And I will just put this out there so you all know about it, because for a long time I didn't know about it. But ECMC has a help center, and it's open, I think, 12 hours a day, and you can walk in if you are in mental health, if you're in dire mental health straits and you don't want to go the crisis services route, or you don't have a care provider, you can just walk into this clinic and get care. And I don't think most people know about that. So I'm telling you all that exists. So now that you know, and you can put it in your toolkit for anyone who might need it.
Thank you, everyone, for that insight. And I would just like to say, I want to follow up to what Judge Martoche just said, but also let the audience know that you are welcome to ask questions in our chat box, and Eliza and I will monitor that and ask them as when it's appropriate. But along with that point that Judge Martoche just talked about regarding the ECMC Help Center, what other medical or health resources and what other legal resources are our systems doing or coming up with that is in place to help individuals find themselves in trouble, or just seeking more knowledge, or to try and be more proactive with some of the issues with like mental health in our communities? What resources are out there that we may not be aware about?
I would say, like, from a mental health perspective, there are now, it might be different numbers in different jurisdictions, I'm not sure, but mental health crisis lines are now national, from what I understand. So, 24/7, you can reach out, trained counselors, are available. Community health centers, like where I work, we do have mental health capacity. We don't turn away anyone. If you are in crisis, if your family member or friend is in crisis, going to a hospital like ECMC or University of Pittsburgh Children's or wherever it might be, to get help, and that it's okay to ask for help. And I say that because, I see a lot of adolescents and a lot of just people from all ages of life who are under tremendous stress. The sandwich generation, as they say, people caring for their parents who are getting older and ill, but then also caring for their teenagers or younger kids. They're not sure what to do. People are under tremendous financial stress. just to normalize, to have these discussions that it's okay to seek help. It's okay to feel vulnerable. It's okay to feel depressed. It's okay to ask for help. And I think that a lot of times with social media, I'm from a generation that didn't have social media. We didn't even have internet. So, when all that happened, and then now we have social media and people are posting on, TikTok, Instagram, Facebook, Twitter, whatnot, right? And everything looks perfect and great. And that's not always the case. So to be involved in your friends' lives and your family members' lives, your coworkers, to say, a mentor of mine says, you want to be in a workplace, and these workplaces don't always exist, but you want to be in a workplace where you can, when someone says, "Hi, how are you doing?" I mean, what do we say? We're like, "Oh yeah, we're great," or, "Great day," or to be like, "I feel really tired today. I don't feel so great. I had a really stressful day yesterday," to be able to say that it's okay. That would be wonderful if we could actually, have that level of discourse.
Thank you for that, Dr. Subramanian. And just to follow up with that, we're as coming from the perspective as a woman, do you or any of our other panelists think that being a woman is an inhibitor for gaining certain access to medical care?
I'll go ahead and say absolutely yes. I think that especially with pre and postnatal stuff, again, that's kind of my scope, but I think that women and especially mothers are kind of expected in a lot of ways to suffer, and we almost pass that expectation on to each other. And it's a generational thing, right? There's many paradigm shifts. Paradigm shifts have many different stages. So we're now in this phase where women and marginalized groups are making up, 50% of the medical community as the providers. And so now we're kind of starting to shift how we really need to be taking care of these patients. And we're still we have quite a long way to go, I think, as to how, to make sure that we're acknowledging our patients' concerns. But I would say the most frequently ignored or diminished or minimized complaints or issues that I see are from my women patients who have gone to many different male physicians, and that it's a trend, and maybe it's because I'm biased and I'm looking for it, but I do think that there is quite a lot of stuff that gets kind of swept under the, oh, well, that's what happens when you have a baby, you're going to have back pain now, you're going to have all of these things that are just expected to be part of your life after you get pregnant, or if you're a woman and you have PCOS, or if you have endometriosis, it's just kind of your cross to bear. So I think that advocating for yourself and knowing your body and going into your provider and saying, no, this is an issue for me, is something that, is not necessarily our first line of thinking. That's not how, we're always like, oh, apologizing for way too much and kind of being a little bit more timid and not really having as strong of a voice. But I think I'm hoping to kind of see that shift. But to answer your question, yes, I think that it is a barrier to healthcare.
Do you think just because you're in the I guess OB area, do you think that there has been an increase in home births due to the type of care that women feel like they're receiving in the hospital?
Yeah, that's a really good question. I think that there was an increase in home births specifically because of COVID. I saw kind of quite a big shift. People wanted to avoid hospitals, but I tend to see more of a lack of care on the postnatal side of things. Once the baby's born, the prenatal is all like you checking on everybody and we're making sure everybody's healthy and happy. And then it's when postpartum baby's out and there's a lot of complications and that are kind of just, there's 2 checkups postpartum. And that's really it. And so I tend to see a lot of there's no core rehab, there's no care post C-section a lot of the time. And so I think there's just an expectation, like I said, you know, you've done your job to have a baby and now it's your job to take care of it. And there's not a lot of access on that end of things, but that's I'm going to look into that, the home births because of hospital treatment. I'm sure you're right. I'm sure there's something there.
And I, from a pediatrics perspective, I think, you know, I was talking with a friend recently about this who's going into OBGYN that, you know, we on the pediatric side don't do a good enough job at our, you know, 2-week, 3, you know, we see the baby a lot when a baby's first born. And we don't do a good enough job of checking in with mom at those visits. I think, you know, it's a very, and I will keep in mind to be better about this when I see newborns, you know, not just kind of, how are you? Okay, let's take a look at your newborn here. More, you know, delving deeper into postpartum depression, postpartum blues, any kind of further issues that are going on, kind of related to those in the pediatrics world. So that's, I think, also happening.
I also wanted to add from my perspective, you know, I see people across the lifespan, and I know a lot of women talk about waiting years, sometimes decades for diagnosis, you know, things like endometriosis, like Dr. Berntheizel talked about, you know, which is an extremely painful, or can be an extremely painful pelvic pain condition, but things like heart disease, like, you know, women die at much higher rates than men of heart disease, of, you know, GI disease, many cancers, because all the research and all the things that medical providers are learning about in school is based on male populations. So like, for example, with heart disease, you know, the kind of example that comes to mind is, oh, you know, the person has, you know, crushing chest pain and left arm pain and jaw pain and sweating. And that may not be at all what a female patient experiences with heart disease. You know, they might have an uneasiness or maybe some like gastric stomach kind of upset, or even diarrhea, or, you know, other things that are not the, you know, classic chest pain. And then what happens is it might be too late by the time they're diagnosed. So, you know, there's a lot of, I think there needs to be so much more research and study and, you know, real focus on female populations as well. So just with any disease really, and how it might be different or the same in them.
So just as a follow-up to that, do you think that is the lack of protections for women, do you think that relates back to like medical school, like how the educators are teaching the students, or why do you think that is? And I'm not trying to, this is just trying to get the what you all think is the answer, but just I'm interested to see where you think that lack of protection for women come from. It's been an ongoing thing for a very long time now, it appears.
I guess I'm pretty close to the medical school process, so I guess I might be able to speak to this one. I think there's a lot of factors that go into it. I think in the medical school curriculum right now, at least UB, it's the only one I can speak to, is they're getting better at kind of talking about women's health and the fact that a lot of what we know is based off of studies done on, you know, white men in this country, and that doesn't apply to nearly everybody. So, you know, we're getting better at talking about that. I think we're talking about kind of how we can do things differently, but I don't think we've reached the step of like doing things differently yet, because you are still seeing people waiting years and years to get diagnoses that, you know, if a clinician was attuned to, you know, issues outside of, you know, their own population, if it is like a white man or something like that, you know, I just don't think we're taking that extra step yet. But we are starting to learn in lectures. You know, we get a lecture on, you know, heart attacks, and it doesn't just go through the crushing chest pain that goes to the left shoulder. You know, we learned that data was based off, you know, a population that is not representative of the true population.
I think too, just going back on what Dr. Nat said, I think that there's a whole bunch of different layers again to, my mom is a physician and she was trained by men, and she was one of 25 women in a class of 500 people. So I think the further away we get from just men and really homogenous populations as the instructors and the professors, it's not just the data and the studies, but it's also the taught experience. Like my clinical pearls that were most valuable were from professors who were telling me about a patient that they had that they learned from. And so it's not necessarily just the academic side of things. I think it's really the clinician to clinician past pearls of wisdom that we're now starting to really pay a lot more attention to. And I again might be biased, but I really feel like I can tell which OBGYNs were trained by women and which were trained by men. It feels really different to me. And so it's trying to let go of my own judgment about that, but it seems like it really does make a difference clinically for what patients experience. So I think as we get, it's slow, but we're getting there.
Okay, we have a question. Okay. All right, this perfect question, because we were going to kind of pivot into I guess the legal landscape of what's going on and how it affects women's health and right to access. So just to pose, kind of a question amongst all the panelists, what do you all feel is what is the legal system doing and what's in place right now to, I guess Jamila talked a little bit, we talked a little bit about this already, but I guess in terms of access in general, what do you all see as healthcare providers and a sitting judge who deals with many different aspects of, I guess, access to health? What do you see right now within the legal system and what's happening and how that affects the population that you all see on a daily basis?
Sorry.
No, so I read the question, which I think was geared toward, I think it was reproductive, what's the current status on women's reproductive rights, I should, to put it that way. And unfortunately, as a sitting judge, I can't comment. I mean, I can tell you what the state of the law is, but I'm not able to do a whole lot more than that. So I'll tell you that the Supreme Court decided the Dobbs versus Jackson Women's Health Organization decision, and it considered a case to determine the constitutionality of a Mississippi law banning abortions after 15 weeks. And as we all know, Dobbs overturned Roe versus Wade and Casey versus Planned Parenthood. And so the state of, I mean, I can tell you again as a fact that the state of access to abortions as part of women's health care is now, it's changed. The landscape has changed significantly. And there are it's a hodgepodge now, and it really depends on the state that you're in as to what it looks like. And I think, New York State looks different than Mississippi. And so it really has gone to the state legislatures to define what's permissible. The constitutional protection that had been in place for 50 years is no longer there.
Thank you. Yeah, and I guess just to piggyback on that, from a really high level perspective, and in very much layman's terms, basically what happened when Roe v. Wade got overturned was that the power to restrict abortion went back to the states. The power to do that went back to the states. And that's what we're seeing now. And I think that sometimes gets lost in translation with trying to understand Roe v. Wade and the implications of it. But that's really what it comes down to, is that each state can choose what it wants to do with access to abortion. So, and so kind of going off of that, and this is addressing Maureen Hayes Mitchell's question, but if panelists wanted to just speak about your perspective on prospects for women's reproductive health in a post-Roe environment. And obviously, like Judge Martoche said, that's a different answer in each state, but for the states that you all work in, or states that you see patients either going to and from, just sharing your perspective on what you're seeing now and how you anticipate that changing as access becomes harder in more and more states.
I can start off. So I think, very recently, the CDC put out new data about maternal mortality in this country, and we rank last in developed countries, which is, should be astounding. But I think with the state of our maternal health care, it's unfortunately not astounding at this point. But it's increased an incredible amount in the last year, and I think that in a post-Roe world, that's not going to get any better. This has existed for a long time, maternal mortality being higher than in other countries. And it would be remiss to talk about this without saying that that's much higher for women of color. And I think that is going to get much worse in a post-Roe environment. I think, we have strong data to tell us that in kind of restrictive states, maternal mortality is worse, perinatal mortality is worse. So babies kind of in their first month of life have a higher risk of mortality, in their first year have a higher risk of mortality. There's higher risks for, in restrictive states, for poor maternal mental health outcomes. There's kind of an impact on socioeconomic status as well. And then there are implications for the medical field. There's in states that have more restrictive abortion laws, there are already kind of maternal care deserts, so lack of access already to adequate maternal care, which can impact birth outcomes and maternal mortality already. But providers leaving those states because they don't want to kind of practice there, face the legal implications of that. And then also medical students choosing where to do their residency may choose elsewhere to go. So I think there's so many implications, but I think that's my broad overview of kind of where we are right now.
Yeah, I would also add to that I am in an area that the mayor of Washington, D.C. has said very clearly and forcefully that, she will uphold the DC area's reproductive rights for all people with uteri and female organs. And she said it like that. And I know there are people coming from other states, to our region to get reproductive health care. There are people asking for reproductive health care maybe earlier than they might have, because they're worried that the laws might change. And I think it's become something that's on the forefront of people's minds. And I think, I'm glad Dr. Voos talked about the equity piece, because, in DC, some years ago when I was a community health fellow at Georgetown, I worked in some of the most under-resourced parts of DC, providing care and doing research and such. And the maternal outcomes 15 years ago were equivalent to that of some sub-Saharan African countries. And that was like 2 miles from the White House. And that was 15 years ago. So think about it now with post-Roe, what's going on, and, why are Black women having such poor outcomes for, maternal child mortality. Like, why is that? There's systemic racism, there's lack of access, there's so many things. But I think that, we as healthcare professionals and the public, we really need to realize how, the fires are burning, and we need to rise up and step up and again, advocate for policy change. If you're in an area that does not have these protections, especially like in your states.
I think just to kind of piggyback on what all of you said, I am lucky enough to be in a state with wonderful amounts of access. And every day that I'm treating pregnant patients, I'm thinking about how if we were in a different state, it would look very different if they had a miscarriage. So I want to just really highlight that these laws are not just restricting healthcare for people who are electing to have an abortion. It's a lot of really necessary, life-saving, not that there's any difference in importance of those two things, but I think that it's just really, it's important to highlight that it is across the board. Access to pre and postnatal care is already very lacking, especially for women of color, especially for lower socioeconomic statuses. And so already, we're kind of really swimming uptide here upstream. So I just think that remembering that if you are in a state with really, really wonderful access, that it's an immense amount of privilege, and it's an immense amount of importance to hold on to that with a death grip, and to put all of your access and all of your energy, I think, into, reaching out to people that, in states where there is less access, and really trying to get efforts on the ground where we need them, because it was very, very scary the first few weeks. I have some patients who work at Mass General, and they had people flying in those first few, the gray area weeks, where doctors were being forced to make legal choices, not knowing, it's asking medical professionals to do, to practice law, and they're not trained to do so. And it's, I think, upsetting on so many levels. But if you have the rights still, and you have the energy to just try to focus that elsewhere for policy change in states where they're not so lucky.
Thank you. Okay, well, we do have another question. Unless there are any, I guess, just going along the same lines of access to healthcare, if there's anything else anyone wants to bring up as a topic, tangential topic, subtopic, feel free to do that. And then we can get on to the question that Morgan Baker posed.
I mean, it sort of dovetails, but I think it just needs to be said in this group that another impediment to healthcare for women, it applies to women who find themselves in a trafficking situation or in a domestic violence situation. That often one of the first things that goes if you're domestic violence, or human trafficking survivor, is that you don't have access to healthcare. And when you do, someone is controlling it or monitoring your access. So, I know that when I see someone in my courtroom, and someone may be a defendant, and let's say they're a defendant in my human trafficking court, and they're looking back to the audience, to someone about, should I say yes to this? Should I not say yes to this? These are public proceedings, and they're very constrained by someone who's controlling them. And that happens in the healthcare field as well. I can't tell you the number of people who have said, I went to the emergency room and my abuser was my interpreter, and was the person who was telling the physician, the nurse, the story. So didn't tell the full story about how I got my injuries, or didn't let me have any time alone with this person. So I just think as we think about access to healthcare and what are impediments, that's another significant piece of it that we should all be aware of. And and it's far more prevalent, trafficking, domestic violence, than I ever knew or believed. And it cuts across every socioeconomic, racial, every swath of person could be trafficked or abused in a domestic violence situation. I mean, as a judge, I I presided over cases where the defendants were youngish women who had been honors students, all-star athletes, and then something happened and their life kind of unraveled. So I think it's helpful to just remember that it can happen to anyone.
Thank you. Nat?
Oh, sorry. I guess so. I would love to just I know we're in kind of the waning minutes here, but to bring up kind of a piece of access like slash advocacy that I think also just kind of needs to be mentioned in a discussion like this. So, you guys probably can see I don't look like a lot of people who graduated from SEM. So I think transgender health access and care is a huge part of what I care about. But I think in a conversation like this, just remembering that, the conversation needs to go beyond cisgender women. So when we talk about, I kind of like to think of it like not everybody with a uterus is a woman and not everybody who's a woman has a uterus. So kind of framing it like that and remembering those things. And when we talk about women's health, right, we're also including transgender women in that. And I'd go as far as saying, gender affirming care is women's health in that aspect. And we talk about reproductive health, remembering that non-binary people, transgender men, kind of also fall under the category of people who are affected by, any of the reproductive topics that we talk about. So I think there are a ton of issues and I could go hours and hours and hours talking about it. But I think what I kind of would love to leave the group with is to not leave this population out of the discussion, right? They have a seat at the table. And it's an important seat. And I think right now it's a seat that is, gets a lot of political attention, but, it, I think, needs to be discussed and seen as an equal part of the table.
Thank you so much for sharing that. And I'm glad that we have you here to educate us and bring that really important topic to the table and conversation. So thank you. So we wanted to end the panel with, we have one more question, I guess, if people want to stay over a few minutes. We have one more question from Morgan Baker, but we also wanted the panelists to be able to share, and as Anne Michelle wrote in her question, if you could wave a magic wand over healthcare, or any of the topics we mentioned today to fix 3 problems, which 3? And we wanted to have the panelists be able to kind of give a takeaway to begin with. So this is a perfect way to end. And if anyone wants to stay after that, then we can address Morgan's question, anyone else who wants to stay on and ask the panelists questions.
I can go. So I would say if I could wave a magic wand, it would be to infuse lifestyle medicine into each and every encounter in this country and all over the world. And what do I mean by that? So lifestyle medicine is the scientifically based, evidence-based strategy where you use 6 different pillars to treat chronic disease. And those 6 pillars are good nutrition, which is plant predominant nutrition, physical activity, optimal sleep, social connection, and substance abuse reduction, including like tobacco use or alcohol. And I'm sorry, I'm blanking right now. It was at 6. Anyway, those are the 6. So physical activity and nutrition, and then social connection, sleep, stress reduction, and substance abuse reduction. So the way that I see it, so $3.5 trillion in this country right now is spent on healthcare. And 90%, up to 90% of that is on chronic diseases, which are preventable. So what do I mean by that? So we all have genetics, right? We all have genetics. We have parents that gave us, tendencies towards this, that, and the other, but how we live our lives makes a tremendous difference in whether we will get diabetes, or whether we'll have heart disease, or whether we might get some types of cancer, or even whether we can modulate, whether we can improve our mental health or not. I mean, there's tremendous research going on about the gut microbiome, so essentially the bacteria in the GI tract, and how it can influence mental health. It can influence outcomes on your immune system, on cancer risk, on all these things. And it might be puzzling to people, well, how do you do this in a under-resourced setting, like where I'm working with homeless patients, or I'm working with, people that just don't have a lot. And, a lot of this doesn't have to be expensive. So, you could work with someone on, if they're going to a food pantry, like rice and beans, or, canned vegetables, or the dollar store has amazing resources, to get frozen vegetables, or, grains, or beans, or, other things. But it's really like, if I could wave a magic wand, is to get all of you and your healthcare providers and the general public, like, talking about, why do we have $3.5 trillion in healthcare spending, and yet we're struggling with mental health? We're having this forum, we're talking about lack of access to reproductive care, to mental health, health equity. I could talk for hours about health equity, but I really see, looking at the root cause. So there's a great cartoon that is often cited, where you have, a bunch of healthcare providers that are standing next to a bathtub, and the bathtub, the faucet is on full force, and the providers are mopping up the water that's falling out of the bathtub, but no one is addressing turning off the faucet. And what I mean by turning off the faucet is, if you're eating Lunchables in your school lunches, I don't know if you've heard of this, but Kraft Heinz is going to put a form of Lunchables into everybody's school lunch now. That is not a healthy thing. There's a class 1 carcinogen in that Lunchable, and that is called processed meat, and people don't know that. And they're like, okay, Lunchables. But if you're going to have Lunchables in your school lunches, you're going to have no recess, no physical education, in school. You're going to have, parks are not safe for folks to walk, bike, or be in. You don't have all of these things in your community to help support your health. Then sure, you're going to go to the doctor or healthcare provider, and they're going to give you medications, and then they're going to give you more medications, and then you're still going to feel cruddy, and you're going to get sicker, and then you're going to end up as somebody that may have a profound long-term disability, or unfortunately pass. And I just want to leave everybody here with the message that we can change our stories. We can change our stories by how we eat, how we exercise, how we reduce our stress, how we live. And there are people, many others like me, but many others who really are trying to focus with their patients and the community on doing this. So I really wanted to leave everybody with a message of hope. Like, you don't have to get many kinds of cancers. And I can say colon cancer, breast cancer, many kinds of those cancers are not, they're not because you have the genetics. It's the environment is definitely, interacting and promoting that. So I hope that's helpful.
That was wonderful. And I also want to steal some of that and say exactly what you said, but also from the provider perspective. I think that if I could wave my magic wand, I would say I want to educate all providers, exactly what you just said, and also have them get out of this mindset of, okay, I am an endocrinologist, so I'm going to work with the endocrine system, and trying to zoom out a little bit and look at the person in front of you, and look at the education background, the socioeconomic struggles that they may have faced, the racial inequality they may have faced, all of the things that are stacked against that patient. And actually, you know, that's what medicine should be, right? Is the doctor kind of communicating with the patient and really tailoring their care to that person, and not just going through this motion of symptoms and then this is the drug I need to give them and this is the prescription and this is the plan. So I think I would love for patients to be educated on that side of things, but also for clinicians. The patients are oftentimes the ones advocating in a really good way, and the provider is the one that ultimately makes the call. And so sometimes I think, you know, it's a challenge to not get overwhelmed when you zoom out. I feel that burnout pretty quickly. If I look too wide at the system, I feel paralyzed by it. But I think just looking at the whole patient in front of you and really trying to have a more personalized approach in how you're treating people, that would be my wish for at least one of my wishes.
I have a lot of wishes, but I guess I will kind of sum them into like, oh, it sounds so broad, but like increasing access, right? I think, you know, I would love to see our country move towards single payer. I would love to see more residency spots in this country made available so we can have more physicians. I would love to see medical school become more accessible to, you know, lower socioeconomic statuses and people that don't just have the privilege to pay for their MCAT courses and things like that. I think that's my wand is just access in general, and there are so many ways to accomplish that, but those are a couple.
And I'll just dovetail and say, you know, if I had a magic wand, mine would actually be to have everyone have an education like SEM. Because I think so much of what we're able to do is because we were just gifted this incredible education. And so we need to take it, right, and advocate and use our power and our voice to advocate for all of the things that we believe in. You know, SEM girls and boys, and anyone in between. I mean, we are not known for being quiet. So we need to continue to raise our voices for what matters.
Absolutely. That was a great little mic drop moment.
Yes.
I think we should soundbite that and send that around.
That was really great. Thank you everyone for your wonderful contributions. I know I don't want to be remiss and not give our fearless leader her chance to speak, Helen, but I just want to say that I learned so much from all of you. You all are phenomenal. And I actually plan, I'm a little selfish right now, but I plan on following up with a couple of you to bring you back to UB, hopefully. So be on the lookout for my email.
Well, thank you. And I am in awe, and I'm very proud of SEM and Amy. Thank you. But the school really has, if we have more SEM women in the world would be a better place, as Kate Bowen Smith would say. And SEM women, SEM men, SEM graduates, it doesn't matter. It's people who will advocate and speak. One of the things that is very clear to me that we are one of the few schools that has a 4-year health and wellness curriculum in the school. And after my own personal experience, and Asha, this gets to you, there were lifestyle choices I made that may have affected my diagnosis with breast cancer. And if we're not educating in high school our students, the choices they can make and how they choose to live will affect their long-term health. I think it's enormous. So we are looking a little bit at a curricular adjustment to make sure we are addressing very specific health issues that attract women. But also, as you know, I'm starting to think about retirement. I've got a lot of work to do in the next 14 months at SEM, but this advocacy as a woman, as an educator, as someone who believes in healthcare access for all, I see a little avenue for myself. This evening's really opened up something for me personally where I can see myself taking some action. So I am very proud to be at SEM for all the reasons Amy said, and I am extremely hopeful after this, after hearing from all of you and our graduates who are equally as committed to this, the access and healthcare in general. So thank you. And I could ramble on, but I'm done.
Amazing. Well, thank you all again so much for your time. Special thank you, Eliza and Jamila, for moderating, and for, our 4 panelists. I certainly appreciate your time and your insights and your willingness to share your expertise with our community. I know we do have like a couple other questions that came in through the chat. I don't want to hold everyone up for the night, but I know some of our panelists are willing to stay after for a few moments, but I will sort of dismiss the broader group. But if you want to stay back and chat with some of your former classmates, please feel free to do so. Also, subtle plug, we will have another alumna speaker series in early May, so please look out for that email, and I look forward to hopefully seeing you all there as well.
And also thank you to Jane, because she has spearheaded this entire speaker series, and she has been the backbone of all of this, and truly this would not have been possible without her. So snaps for Jane.
Jane and Karen, thank you so much.
And Karen, yes, thank you.
Keeping us on track.
Jane, Karen, Eliza, all of you.
Amazing.
It's a pretty powerful, when I look at this room, this is a pretty powerful group of people, and it's exciting. So let's harness that.
And Jamila, sorry, I missed that. Jane, Eliza, Jamila, Karen, great job. Fascinating.
Amazing.
And this will be posted, won't it, Karen? It's been recorded. Good, because I know there are a lot of people who couldn't make it who are very interested. Excellent.
Yeah, we'll post it on the website tomorrow, and I can send all of you links if you'd like to share that.
Great. Thank you.
You're welcome.
All right. Well, anyone who needs to drop, feel free. But if anyone wants to hang back and continue to discuss, share ideas, whatever it be, you're welcome to.
I'm going to pop off. Anybody stop by anytime. Those of you local, those of you who aren't, we'd love to see you on campus. So thank you.
Thank you.
Well, Morgan is still on, so I will read her question for our panelists that are left and see if anyone would like to answer it. But her question is, with physician shortages, retirements, burnout, population growth, and burnout, it can seem as though there just aren't enough providers to treat patients, and that this will continue to be the case for some time. What are some ways, if any, that you've seen physicians, institutions, care providers narrow the care gap for patients who need treatment in the short term? What solutions can you imagine?
I know, at least in the settings I've worked in, that, telehealth has become really popular. And, prior to the COVID-19 pandemic, there wasn't a lot of telehealth. There were a lot of state laws that were very strict around it, and those were relaxed so that, people could get access to care. So, there are practices now where medical practices where they're completely telehealth. There's even mental health telehealth available. The big insurers, Care First, Blue Cross Blue Shield, Aetna, United, you name it, a lot of them have access to telehealth as a benefit if you have insurance. Even in our community health center, for folks who don't have insurance, we do have telehealth. So that's one thing I see for access to care. I mean, even though you might not be able to get in to see your provider, or there might be a long wait, but you could get a telehealth visit faster. The use of mid-level providers also. So, we have physicians here, but also physician assistants, nurse practitioners, doctor of nursing. There's so many mid-level providers that are also plugging the gaps in care. But really, I'll come back to what I said, which is I want to be put out of business. I don't want to have to take care of really sick people because I'm helping them stay well as much as possible. Obviously, so many things we can't prevent, or things happen, but there are things we can do about chronic illness that we don't have to spend 90% of $3.5 trillion on chronic illness. Like 70 to 80% or more of chronic illness can be impacted by how we live. And really educating yourself. Like don't trust anyone. You're a SEM grad, everybody here, right? So read the literature, read the scientific literature, or go research it, form your own opinions, really understand your health conditions. And I can say this, I am the survivor and thriver of a chronic illness. And I actually started my journey like from quote unquote, like regular medicine to lifestyle medicine, because the medical establishment did not have a treatment or cure for my illness. And, that's how I got started. So, so many people, when you start looking, you can't unsee.
I think going off of your point, Dr. Subramanian, I think that there are a lot of, going back to the siloed method of medical practice, I think that there are, even within medicine, a lot of us are either, traditional healthcare or alternative healthcare. And I think that it's really worth noting that the patients that usually get better are the patients who are doing both things, and who are kind of really, not just going to get acupuncture or seeing a chiropractor or going to physical therapy, but also taking medication when necessary. So I think, again, zooming out and kind of recognizing that it doesn't have to be one or the other. And that if something is helping a patient, if something is, not harmful and not astronomically expensive, and they can access it, that, you should really encourage that. And I think it's not just, there's no one size fits all treatment plan or solution for, it's not going to work for every single person. So I think really acknowledging if something is helping you, to continue to do it. And I think staying away from the binary model is also going to be helpful for kind of meshing those two things together.
I was going to say almost the exact same thing. Expanding, the amount of providers you use, and then, moving away from this like paternalistic version of doctors that, it's only the doctor who can make the decision. It's only the doctor who can provide the treatment and the counseling. And that's not how our medical system works anymore. And it won't work, and it will just be burnout and all of these things. So using, having more offices with social work built into the office structure, having offices with nurse educators built more into the structure, having those kind of long-term, more sustainable uses of other healthcare professionals other than just doctors is really, really important. And then, mid-level practitioners and PAs, NPs, chiropractors, everybody there kind of working together. And I think, Emma, you summarized it beautifully. Like, the people that get better are using both. And if somebody's doing something that makes them feel better, we shouldn't shy away from it, So I think you said it very nicely.
Thank you. I also want to mention, I work at a multidisciplinary clinic, and I have physical therapist colleagues, I have acupuncturist colleagues, and we all triage people and share patients, and the difference in how people respond to that. When I literally walk to the room next to me and I talk to my physical therapist colleague about what she saw today and how we can both, change our treatment plan if we need to. It's the patient, it's like they say often, this is like the absolute first class treatment. This is the most incredible treatment I've ever received. And it's because two clinicians that are treating them are talking to each other. So I think just keeping in mind how huge it is to just call another physician that's working with your patient, or communicating with other healthcare providers that normally you wouldn't necessarily, there's a gap that you wouldn't bridge, is really beneficial, not just for you clinically, but also for the person that you're working, for. So trying to help.
I think also too, I'm not a panelist, but just to chime in, because I know Nat had mentioned this earlier in the panel, that the cost to go to school, not just, medical school, but PA school, NP school, I'm sure chiropractic school, I don't know anything about tuition for that, but I can't imagine it's cheap, but it's so cost inhibitive that people can't, it's such a risk to do that financially for so many people. And it's the same with law school too. If you can't afford it, you just don't do it. And it really disproportionately impacts people of lower SES. And like we talked about, there's a big racial gap in medical and legal providers because it's so cost inhibitive. And that, I don't know how we fix that. If anyone has an answer, please chime in, but I think that is a big part of why, we don't have as many people going through the medical education system, the legal education system, and what Nat said earlier too about residency spots being limited. And, that's true, I think, across a lot of professions. And it's a shame. I don't know how to fix it.
I think in the same light of Nat's point about single payer systems and, that being the goal, I think it would be the same thing I would say for, reducing medical school, chiropractic school, all of that tuition. If you're going into healthcare, I don't think you should have to pay for schooling. I just think it's like such a sacrifice to, dedicate your life to that much education, but then also to every single day, there's a lot, especially with the boomer population now requiring so much healthcare, and there really truly not being enough providers. I think that if we can, or even just reducing the interest on the tuition, on the student loans, would make a big difference. COVID, thank you, COVID, for like saving all of us tens of thousands of dollars on interest. But I think that even just acknowledging that it shouldn't just be the doctors who are working in low socioeconomic populations that have debt forgiveness opportunity. And I think that is, obviously there's incentives, there should be incentives to work in those communities because they need more help. But I think that if we were to reduce the tuition and kind of work towards that in policy, that would be huge too.
Not to put too fine a point. Oh, sorry.
I was just going to say, and I'll let you, but I was going to say, I think you guys are on your way. Look at this, your generation, very different than my generation, already talking together about this. And Asha and Amy, I think you're kind of the bridge between mine and yours. And to me, this is really exciting to hear. This conversation makes me think, oh, you guys will figure this out. And you'll figure it out for the rest of us. I'm excited. So sorry to interrupt, Nat.
Oh, no, that's okay. I was just gonna, not to put too fine a point on it, but there are like, I believe NYU, like when I was applying to med school, I know this was a huge thing that came out the year that I applied. There's like, if you are like dedicated to going into a primary care profession, I think it's either free tuition or very, very low. That's the only school I know of that does that. But moving towards those kinds of systems, I think is really kind of imperative, because the system we have right now is just like self-fulfilling cycle, right? Because like you go into $300,000 in debt, you're not going to want to go into primary care for profession that makes half of what a surgical colleague makes. So it's going to keep happening until we do something, because it's pretty hard to leave, from a personal perspective, like to leave medical school with $300,000 in debt, looking at a pediatrician's salary, which is quite literally like either a fourth or a half of what, some of my colleagues who are graduating in orthopedic surgery are going to make. So it's just, that's what I'll leave it at.
Well, or is it possible for the medical profession to heal itself? That sort of income differential is really unconscionable. You know what I mean? Certain specialties earning so many times more than others.
I think that's insurance companies, which is a whole nother rabbit hole.
Yes,
I'm not
that's
blaming
it.
the
Insurance
orthopedic
company,
surgeons, but
pharma,
I like that was
hospitals.
just an example there. I think it is
boy.
insurance and all that fun stuff.
Yep. And what
Well-
they value.
Well, get one of your classmates who's working in insurance, speaking with you too.
Yes.
Let's get all the players at the table here and
Yeah.
see what you can do.
Yes, and the doctors who are consultants with the insurance companies, because they can make so much, so they feel themselves pushed that way as well.
Great.
I will say, I think, Helen, you said it. I think Gen Z is coming up. They're angry. I think, things will change and we'll see that. But I think, my generation medical students and younger, I think we're getting a little sick of it. So I think you will see change, hopefully.
Yay. Now I really am leaving. I said I wasn't, and I got it. Thank
Well,
you.
thank you. Yeah, thank you to everyone who participated. I also have to jump off, but you all are welcome to continue chatting. I'm sure we could chat all night
Yeah.
long. But thank you all so much. This has been really wonderful.
Thanks
And
all.
thank you to our
Hope to see you all
tri-chairs
soon.
for making this happen.
Thank you, guys.
Thank you.
Thank you, everyone.
Thank
Thanks
you.
all.
Thank
See
you for
you
having
soon.
us.
Have a good night.
Bye-bye.